On occasion, we will have one of our clients or our patients arrive at the clinic complaining of something, and we will think it's a particular area and try and attend to that. One of the beauties of using a sort of a format, the logical format of structure, cause, mechanism of pain and contributing factors, and using it in a logical sequence, is it gives us a great deal of information. In the case of the model here, he actually just happened to mention he had thoracic pain in the area around his scapula and his thoracic spine. And we looked at it. Now, the tendency is often to look at the contributing factors, or once upon a time, and say, okay, he's got a bit of a scoliosis. We can see a slight scoliosis here, the bulging of the scapula due to the rotation of the vertebrae. And he's a barman, he's working physically all the time, long periods on his feet. So, okay, it's because you've got a scoliosis, and try and fix that. The problem is when we look at this sort of crookedness, as Paul Ingram kind of phrases it, or these asymmetries, it's not always relevant. This chap grew up with that, and this pain has started to bother him, although he's had episodes of it, has really started to bother him in the last few months. So I asked a few questions, and we kind of looked at it and looked at it in a little bit more depth. And as I said, we used the structure, cause, mechanism of pain, contributing factors, the SC-MC method of clinical reasoning. And I got him to do some sort of thoracic movements, and which I'll get you to do again. If you put your hands across your chest and just turn from side to side, the whole of your body. And he was actually complaining of pain actually more on the right rotation. When he was rotating in this direction, he was feeling the pain here. So I thought, well, it could be from the thoracic area. Is it a joint? Is it muscular? What's causing it? But let's try and be a little bit more logical and think in a different way. Now, there is a phenomenon known as Cloward signs. One of the more common Cloward signs is a pain in the area of the scapula, about here, that emanates from C4 here. So I asked the client, now we went through a full assessment, which I'm cutting considerably shorter. I did a long subjective assessment, checked into and spoke about some of the biopsychosocial elements, as is the way we are going now. But as being a manual therapist, my emphasis is always going to be on the manual therapy side of it. So I just asked the model to kind of look up to the left hand, left-hand side, bend his head up, and also bend his head over towards me. And he said, oh yeah, I'm starting to feel that down here. And are you feeling it there now? Yeah. Yep. And then I got the model to lie down, and I just palpated around C4, and he said, oh yes, my area, that area is a lot more tender and uncomfortable as opposed to the right hand side. So this sort of fired off a few things, making me think, okay, possibly the pain is emanating, some somatic referral as our pain mechanism is coming from C4. So the structure could be C4, the structure could be an arthrogenic problem. Obviously there's going to be some muscle involvement in these things, as there invariably is, such as trigger points around the vata scapulae, the upper traps, or even in the rhomboids. And then that could be maybe because of degeneration, postural, the mechanism of pain, an element of nociceptive pain, with some somatic referred pain down to the scapula, the medial border of the scapula. So what I'm going to do is I'm just going to treat this with a couple of gentle manual techniques, relieving the cervical spine around the C4 area, and then release off some of the trigger points, maybe with some dry needling techniques. So I mentioned the problem could possibly be emanating from C4. So just to get an idea, we've got the skeleton here, C1, C2, C3, C4. So one of these facet joints, if I move the nerve root, would probably be either this facet joint or here that could be causing the referral downward. And I'm going to use a technique, a very gentle technique, where basically I'm going to slide and glide the joints. Now obviously there's quite a lot of debate and contention about how much we are or where we are regarding the sort of palpation. But I know roughly I'm in this area. I might not be bang on C4 or bang on C3, but I'm going to be in that area. And basically what I'm doing is just a very general technique where I'm gliding the joint a little bit, and then hopefully afterwards the patient's going to feel some sort of decrease in their symptoms. So what we'll do is we'll just take the skeleton and go on to the model. I will come down, I will start at the base of the occiput and just try and count the spinous processes down until I'm in a region of about C4. The work, the pivot point, is going to be coming from this hand. I'm going to be moving his cervical spine in this direction. At the time I'm pushing this direction, I'm going to be lifting it up, a kind of up slip. So I'm going to do a transverse movement this way and an up slip in this way. So I will take my hands underneath, I will come down to the point. Usually what I will do is I will just feel the movement and the quality of the movement at the point of stiffness or discomfort, and that's where I'll work. I will then take my web space of my hand on this side, and I'm now going to push in this direction, and with these fingers I'm just going to come up at the same level and lift up. And so basically I'm doing an opening technique like this. Sometimes you can do a manipulation. In this case you can do a transverse manipulation if you're qualified to do so. I personally am very, very wary about doing any manipulations of the cervical spine. When I originally learned my manipulation course, I used to do cervical manipulations, but now less and less because of the potential damage, and we can get just as good effects just by doing fairly gentle and then more aggressive gliding movement with an up slip and stretching out the tissues. So we can also add in a little bit of cervical traction here, and I can already feel some of the muscle tissue easing off. So eventually we will get some freedom of movement, which we've now got, and we can go on to actually working on some of the trigger points. So we spoke about one of the structures that could possibly be causing the problem, which is C4. We did a kind of transverse movement in the direction of the left hand side with an uplift movement by dragging the C4 or the tissues around it up. That's the arthrogenic element, C4, that could be causing the cloud signs. But there are also other things that we thought during the assessment that may involve trigger points, particularly around the rhomboids. Remember that the sort of the rhomboids, they run from sort of the C7 to T5 down to the medial border, the lower border, or even the upper border of the medial part of the scapula. And they often have trigger points in them. Once upon a time in the big red book, you'd have X marks the spot. We tend now not to work using that. I personally prefer to use the idea that John Sharkey comes up with, where he was saying, you can have trigger points throughout the muscle. So one of the points I will often find, and has happened with the model here, is we found a couple of little trigger points in the area of the rhomboids just here. So now we want to treat them. There are different ways of doing that. We can do it manually, and if you're qualified to do it, even with dry needling. So I found a couple of trigger points. The patient basically said, use the four things I like to sort of kind of use to give me an idea that it's a trigger point. And they said, oh yeah, that's some similar sort of spot to where my pain is. That's a kind of good pain. You're on this special sort of sensitivity. I felt like a couple of little tight bands in the muscle tissue here, and even a little twitch at one point. So they would be some of the sort of subjective signs that may indicate a trigger point. I've got a couple of options. I can use my hands or my thumbs, or I can use the knobble or some of the other tools. We could try deep stroking massage over the actual trigger points itself, or ischemic compression. Now, because I'm getting old and my hands are getting a bit baggy, I tend to use the knobble. I quite like this. I can do transverse movements with it. I can do a deep stroking massage with it, or I can do ischemic compression technique. And so what I do is I find the area of the trigger point, and the patient actually complained here, this was the point that was uncomfortable. I will place the knobble or my thumbs or my elbow on the point of the trigger point. I can hold it down 20, 30 seconds. Sometimes their pain will actually start to refer, and that will give us an indication we are definitely on the right point. And then I can release, just get a little bit of massage to mobilize it out. Sometimes even just stretch the scapula away, the border away from the spinous processes, and then come back in again, find any other trigger points. There's another one just there, and push on that area. How does that feel?
Pain, good pain.
Okay. And we will just hold that. And again, maybe just come in, mobilize it around. Now, with deep stroking massage, this is a nice technique. We can use the knobble to do it. This is a very nice technique for mobilizing the tissues. It's very easy on the hands. It's very comfortable for the patient, and often they respond very well to it. With the inhibition compression technique, we would tend to sort of just hold on. You may get some blanching around the area, and as we release it, and this is the more common type of treatment that people are more familiar with. But this is quite a nice area, a nice way of treating it. One other way we can then go into is we can actually try and dry needle the spot as well by placing a small acupuncture needle into the area. Again, you need to be qualified to do that. So one technique, a very, very useful technique, is dry needling. You should only ever do it if you're qualified. You need to have done the requisite courses for your licensing. Don't just go sticking needles in people. You can do a great deal of damage if you don't do it properly. But if you know what you're doing and you're doing it safely and properly, then that's great. Some of the very basic things, obviously there are contraindications to it. I'm just going to show you the actual technique to try and alleviate the patient's discomfort. One of the things I like to do, although it's not absolutely necessary according to some of the research, although the area needs to be clean, I like to use sterile wipes, and I will use a sterile wipe, one-time use, and wipe the area that I'm going to needle. The next thing I'm going to use is a one-time use of a needle. These needles, we don't sterilize these needles nowadays. We don't use an autoclave to sterilize them. They're one-time use. They come in sealed packets. We take the packet out, open the packet, sorry. You will see they come in a little introducer with a little flange that holds it in. We remove that, and then the needle is going to be introduced into the trigger point. After we've finished using this, we throw the needle into a disposable box like this. Obviously they come in bigger sizes as well. So now we're just going to show you where to introduce the needle for the rhomboids. And again, I want to emphasize, this should only be used if you've done the requisite course. It's within your scope of practice. There is no room for the cavalier use of dry needling, just sticking needles willy-nilly into people. It's just not and should not be done. We're now just going to give a demonstration of how we can treat one of the rhomboids. Again, we said the rhomboids run out onto the scapula, the medial border of the scapula. I found a nice little trigger point here. One of the important things is we do not introduce it straight down, because the lungs, and you could go through the muscles in the ribs or whatever and puncture the lung. We don't want any pneumothorax. So we're going to come sort of at a tangential angle into the tissues. If this is the trigger point which I found just here, you'll explain to the patient, as I have earlier on, that you're going to feel like a little bit of a push, a slight tap. The needle is now in situ, and we will just gently introduce the needle. Now, there are different ways of doing this. Some people sort of prod it in and out like pistoning. Some people twist it. I tend to just twist with a little gentle pressure until I feel the needle grasped by the muscle. That's usually the point that the patient will say, "Oh, you're there. Did you feel that just as I came in?" Yeah. And it's a little bit strange, but it's not too uncomfortable. Now, some people piston in and out. I personally prefer not to do that. I quite like the method where I just push in and I will leave it there for a couple of minutes, and then I will remove the needle, and I may place it back into the introducer, and because it's the same body and the same area, I can do it again, but more often than not I personally prefer to use a new needle. So we've just placed it on, a tap, introduce the needle, we leave it for a couple of minutes, a little bit of massage to kind of relieve the any discomfort, and then give the patient a couple of minutes to rest, let them get up, and that's how we dry needle a trigger point. So the model came in basically complaining of pain that was around the medial border of the scapula. We looked into it in a little bit of detail, ascertained that there are areas from possibly cloud signs from C4. One of the presenting factors was a rotation and side flexion of the neck, and also some trigger points. So now basically what I'm going to do is I'm going to get the patient to look up at the ceiling, look to the left hand side, and side flex their neck to the left hand side, and this brought on their pain going down here. Have you got any pain now?
None at all.
None at all. So if you believe that, hopefully that's convinced you that it worked. Afterwards we did some work when he was contracting his shoulders together, or retracting his shoulders should I say. He was getting pain. Have you got any pain now?
No.
And if I just relax your shoulders, and if I push along this area here where you did have some sensitivity, it's a lot softer to my touch as I feel it. Does that feel more comfortable?
Very relieved.
Okay. So this was one of the things we managed to do, looking at the structure, possible causes, which mechanisms of pain, and did the contributing factors make a great deal of difference? Maybe they're having some influence, the scoliosis and what have you, but we're not really going to be able to change the scoliosis in a person of this age, and well, he's only 24. It's not going to be that easy to change that, and then possibly could cause more problems by doing it. So the emphasis was more on working on the arthrogenic and the myofascial elements, which we did, and that has had both to my way of feeling the structures, a positive effect, and the subjective description is also supporting that.